Good evening, everyone. Here Imran Abbas. Again, we are live. I am live from Dubai, and today we have Professor Mario Mozilla. He's a well-known teacher. He's well-known bariatric surgeon. He's mentor of mentors, and it's great honor to interview such a great figure. My viewers, that you know better than me, we have completed our 5 interview series, and this is a sixth one. And every series was for 6 months, and at the end of every series, we had a sum up session. And this series, in my opinion, is more important because in this series, so we are talking about and also discussing about tips and tricks, and also we have started Deferred live, and today we have Professor Mario Mozilla. He will demonstrate MGB or OAGB. It depends on you. So, but the name, so one anastomosis gastric bypass hybrid technique. Sir, so much thanks for your support, and always you are supportive. Sir, please.
Good evening, my friend. Thank you for your kind invitation and for your introduction. And in a few seconds, I'm going to share with you this unedited surgery is a case of a one anastomosis gastric bypass. And as you told in the introduction. I perform a sort of hybrid technique. It's not exactly the Rutledge original technique, and conversely, is not exactly the Carbajo technique. It takes possibly the best of the two techniques, avoiding passages that I do not consider mandatory when we do a one anastomosis gastric bypass. So whenever you want, I can start with by sharing my video. Tell me,
Sir,
please.
please. Sir, please.
Okay. So.
As Professor mentioned, so we have MGB original technique, we have OAGB original technique, and Professor is going to demonstrate OAGB hybrid technique.
Can you see the screen? Can you see my
Sir,
screen?
we can see, sir.
Oh, okay, so well, the video started a little less. Okay, uh, just a few passages to show. First, the way I place my strokers. I normally prefer to use 6 strokers, and sorry but I want you to see. Okay, this is on the right side of the screen, you have an external view, and on the left side, of course, we have the internal view. I use 6 strokers, one subxiphoid strokers, 5 millimeters, just to lift the lever, and other 5 strokers placed in a sort of pentagon position with 1 stroker is inside in the middle, and 2 at the level of the subcostal margins on the right and left part of the abdomen for working on the sovromesocolic area, and 2 at the level of the iliac fossa, right and left, to work in the inframesocolic part of the abdomen. Then the patient is tilted in a strong anti-Trendelenburg position. You can see the optical trocar in the middle. These 2 trocars are the sovromesocolic area. This is for the liver retraction, and these are for the inframesocolic area. This is a standard disposition of my trocars, and I believe well, there's some friends and great performers of this technique that use 4 or 5 trokers, but I'm convinced that it's not a matter of the number of trokers you use, but the quality of the surgery you give that makes the difference. So to me, it's not important if I make another 1 centimeter hole in the abdomen of the patients. First step sometimes I use is opening the pars flaccida. Have you seen this on the beginning here? And these allow the passage of some carbon dioxide in the bursa ommentalis, behind the bursa ommentalis, and this facilitate the dissection of the second part that is making an incision at the level of the crow's foot and the smaller curvature, and finding the space, opening a window behind the stomach that allow us in a few passages to start to preparing my gastric pouch. Some colleagues at this level makes a very small window. Conversely, I am convinced that it's very important to have to dominate the entire field. So I like to see and I like to prepare plans correctly. So I love to have a wide window that can improve my management of the and preparation of the gastric pouch. So you can see the pancreas behind the opening of the the gastrohepatic ligament. This is the posterior face of the stomach, as you can see, and is clearly on the upper part of the stomach. We have a bougie inside the stomach. This is normally a 36 bougie that I use currently routinely, and when I open it, my window, this is the moment I introduce my stapler. In this case, this is a Johnson & Johnson powered 60 millimeter stapler, and that is inserted at the level on the supramesocholic area. This is my left upper side trocar, and it is the right upper side trocar in the patient, of course. And the important passage is try to gain as much tissue you can to have a long and narrow gastric pouch. This is very important in order to have the longest pouch you can get by doing this technique. That is very important to avoid in the future to have episodes of reflux, of course. Also, it's important to have the stapler meeting in a perpendicular fashion the edge of the small curvature of the stomach. You see, this is a 90 degrees between the edge of the small curvature and the stapler, and this is the moment I fire the first cartridge. And at this level, normally I prefer to use a mid-8 stapler, a gold cartridges, if we talk about Johnson & Johnson. And basically, I go in the antrum, as you can see. And at this level, I start to fashion my gastric pouch. And at the beginning, I prefer to use yellow cartridges or gold cartridges, if you prefer. The first stapling has been performed by using the upper right trocar. The second firing will be performed using the lower right trocar, and we articulate, of course, the stapler, and being sure to have a right plan between the gastric pouch I'm going to tailor, I start to fire and to go for gaining tissue, for gaining space up to EG junction. That is the end of my job on the gastric pouch. Of course, it's very important to have a gastric pouch that is not too stenotic, of course, too tight at this level, and more or less we have 5 centimeters of width at this level. The stapler is well positioned, and firing by firing, we start to gain tissue towards the EG junction. As you have seen in this first firing, the EG, the NG tube is, or the orogastric tube is still retired to avoid any compression from the stapler or even stapling over the orogastric tube. This would be, of course, a problem apart from being a technical mistake. This is the reason I developed this approach by avoiding to use at this stage, at this very early stage, the orogastric tube in my pouch. Then following the third or the second or the third firing, I start to place the orogastric tube in the gastric pouch. Okay, this is the, if you listen, this is my dog barking. Well, and this is the gastric pouch that is tailored, firing by firing, firing after firing, and this is the ghost that sometimes I place inside the field to have an optimal regulation of the white balance. This is, of course, the excluded stomach, the gastric remnant that we are going to construct at this level. If you're interested, of course, you can have a look also on the right side of the screen. You can see me and my equipe and my team working on the external view. In the middle, of course, we have the scope. This is a 30 degrees scope. And at this stage, I start to place downward the orogastric tube, and this make me safe. That this make me give me the safety. I'm not making a pouch that is too tight, and at the same time I'm not compressing or stapling or over the orogastric tube. As you can see, starting at the level of the crow's foot or even below the crow's foot in the antrum gives you the chance to tailor a very long and narrow gastric pouch. In the end, this gastric pouch possibly will have a sort of banana shape or J shape more than being exactly vertical. Of course, going upwards, the gastric walls get thinner, and basically at this level we use a more hemostatic cartridge, that is the blue cartridge for Johnson & Johnson. The liver in this case has a fair dimension. This was a female patient who was about 42 or 43 of body mass index. We also wait 20 seconds before firing the stapler, and after firing, we are approaching the EG junction. Sometimes at this stage, before going upward, I prefer to lower the is angle by making incision at the level of the fat pad that is on the Bertelli lamina, and this helped me to have the best dissection I can have in this case, and to have an ideal visual, an ideal plan, and having the best visual I can get in this case. By grasping the gastric fundus, I lower the is angle thanks to the help of this ultrasonic scissor. In this case, they are Johnson & Johnson scissors, and this is the harmonic case. And sometimes I do this surgery with a ultrasound. Some other cases I prefer to use radio frequency, and in any case the results are optimal, and the hemostasis is a very good quality hemostasia. So opening again and finding the correct plan to find then a meeting point between the posterior part of the channel I'm going to create behind the stomach and the anterior part. The dissection is extended upward. This is once again in order to have the best view, the best visual I can have in this case. I believe it's very important, especially if we mean to use this video in a didactic with a didactic purpose. This is a gauze I in this case place over the is angle, and this is going to be a landmark. You will see later. I will meet working on the posterior face of the stomach. Now I work posteriorly, and I make an incision to find my right plan, and of course being careful not to injury any part of the stomach, or avoiding to divide short gastric vessels that I don't need to divide. They bring the blood supply to the fundus, that in this case is of course spared, and you make an incision at the level of this. Is a sort of tent that we inside, and making this cautious maneuver, we find our landmark posteriorly, that is the gauze we have placed it at the level of the is angle a few seconds before. This helped me to create and to see the right plan. You see on this part on the right side, I have short gastric vessels that I'm not going to divide. There's no need to divide these short gastric vessels, and they bring once again a useful blood supply to the fundus of the stomach. Conversely, I can use the gauze to enlarge my window, and once again to have the best plan I can have in this case. I believe now it's very clear the path I have to follow. Once again, I use a blue cartridge that is introduced in this case on the upper left quadrant, left for the patient, right for me, of course. And this makes the another firing that helps me to gain my final destination, that is the is angle, of course. I always take care that the stapling line is very well exposed. I don't like to overlap the stapler with the firing line unless they are perfectly coincident, and this is what happens in this video. So I go up and up, waiting always 20 seconds to get the dehydration of the tissues. And there's a very interesting study published some years ago that has shown how important it is to get some dehydration of the tissue we are going to fire. We are going to separate with a stapler. This is my route. This is my path behind the stomach, and following we have the final firing that is easy in this case because we have prepared a very fair plan behind the stomach. I remove at this stage the gauze to avoid any overlap with the stapler, of course, and you can see perfectly the stapler anteriorly and posteriorly, and this gives me the safe. I'm on the right plan. These are short gastric vessels that have been not excised, have been not divided. There was no need for this. So following this firing, we will have the final identification, the final presentation of the gastric pouch that is, well, the stomach is perfectly divided. You can see this, and we have a long and narrow gastric pouch that, in my technique, normally has a J shape or a banana shape, if you want. And this gives more tissue, more and more tissue, more and more cloth to have my gastrojejunal anastomosis very far from the EG junction. At this stage, I have no fixed criteria. I mean, normally is the orogastric pouch that shows me if it is better to open the anterior face of the stomach, as I'm going to do in this case, or the posterior face of the stomach. I use the gastric, this gastric bougie, this orogastric bougie, because in my opinion, this is exactly what food does when the food goes down into the stomach. And so if the orogastric pouch offers you the anterior face of the stomach, it is better to open the anterior face of the stomach. That's all. And this is what you're looking at. You see the bougie here, and is where I'm going to open my gastrotomy on the anterior face of the stomach once again, to have later the space, the room for the anastomosis. You can see that the pouch is at this stage probably longer, about 18/20 centimeters. That is a very long, narrow gastric pouch. And that is I believe this is the most important part of all the procedure. This is regardless from any anti-reflux suture or stitches or whatever. The main feature of this surgery is having a long and narrow gastric pouch, the longest you can. The longest you can, the better are the results for this surgery. Now we are opening on the anterior face of the gastric pouch, the gastric pouch. If you can start to see in the back the bougie, the orogastric bougie, and this helps me to open, to widen. There's the bougie inside, and I'm widening the hole to later have the easiest introduction, or to make the introduction of the stapler easier. This is the stomach, the anterior face, the posterior face. And well, at this stage, I prefer to retire, to ask the anesthesiology to retire the bougie to avoid later any overlap when I'm going to do the anastomosis. Then at this stage, the scope is moved in the right lower trocar, to have the best vision I can get in the inframesocholic area. This is the fat, segmental fat. Now with a Babcock grasper, I catch the fats and the colon. Sometimes you have a redundant transverse colon that is moved upwards. Can be useful at this stage if you can to put your patient in a neutral position. Sometimes I do it, sometimes I don't. It depends on how big the patient is. And by moving upwards the fats, the omental fat pad, I can reach the triceps ligament. That of course is my landmark to start counting my jejunal loops. Sometimes, especially of course, in women, you can have women who had a cesarean section to give birth to their child, and this can generate some additions at the level of the omental fat pad. Now I reach the triceps ligament that is exposed the best I can. But okay, now it's clear. We are at the level of the triceps ligament, and I start to count downwards. Well, I have a sort of fixed rule that is, when the patient is between 35 and 40, I remain at 180. When the patient is between 40 and 45 of BMI, I go from 180 up to 220 centimeters from the triceps ligament. And when the patient is between 45 and 50, I can also reach 250 centimeters from the triangle. And when the patient is above 50 or even above 55, I sometimes reach 260, 270, or even 280. And in some cases of patients that were above 60 of BMI, I also have used it in some cases 3 meters from the triceps ligament. But the most important is that when you reach the distance you have planned from the triceps ligament, that can be 180, 220, 250, or even 3 meters from the triceps ligament, you check below the point at the level you are going to do the anastomosis. You check you have at least 3 meters below the point you are going to use make your anastomosis. This place you in a safe position and helps you to avoid any malabsorption. There is some surgeon counting the entire small bowel, and especially for primary surgery, I do not believe this is useful. But once again, if you go at 180 to 50, it's always better to have the safety. You have at least 3 meters below the point you're going to do the anastomosis. Then, of course, you open the hole inside at the level of the jejunum, where point you're going to make your anastomosis, and then your work with the scope at the inframesocolics stops, and you go back at the in the middle where you place the first stroker, and the same position you've used it to tailor your gastric pouch, while at the lower right quadrant, the lower right trocar, in the lower right trocar, you place the stapler. I in this case use once again a blue cartridge, and this blue cartridge lift the jejunal loop, and conversely, with the other part of the stapler, with the anvil, I approach the gastric pouch. My standard anastomosis is 40 to 45 millimeters long, 4.5 centimeters, basically. This is what I normally do. In this case, is once again, the anastomosis is done on the anterior face of the stomach, but this is not a fixed rule. Sometimes I go on the posterior face. This especially happens when I do a revisional surgery, especially from sleeves. And in these cases, it happens that the orogastric bougie offers me the posterior face of the stomach, and so that is the level I open the stomach, waiting 40 seconds, 20 seconds as usual, and firing and constructing the gastrojejunal anastomosis. In this case, once again, on the anterior face of the stomach. The room inside anastomosis is well visible, and I don't have any bleeding, and I can check also the bougie coming down, telling me I'm in safe. I'm on the right plane. At this stage, then I love to make a manual closure. Some surgeons also use staplers to close the hole, but I love to make a manual closure of the gastrotomy and the enterotomy. I start by placing 2 lateral stitches, sort of stay sutures, that give me the borders of my hole, and allow me to give to make an ideal closure of the hole, and a closure that I will perform with a barber suture, as you will see in a while. This is the stay suture, the leather stitches I put on the right and on the left side of my opening. This is a sort of routine. Some surgeons use these, some surgeons don't. Some surgeons use staplers to close the hole. Some others prefer the end of stitch instrument from Medtronic, but I believe that is useful, practical, if you want more elegant, to use a manual stitch at this stage. Then of course, I cut the suture, the thread, and this is for the first angle. Then one assistant takes the suture and offers me the other angle, angle that I use in this case I used to close the angle with another absorbable 3-0 suture. This is a biaxial suture I routinely use in this case. The length of the suture is more or less 12 to 13 centimeters. They are passed on the gastric edge and or on the jejunal edge, of course, and they close perfectly the borders, the margins of the two margins of my hole, and gives me an ideal orientation of the closing of my enterotomy, gastroenterotomy in this case. Once again, there's some colleagues that at this stage are much more faster than I am, because they use other instruments. But I do not believe that surgery is a matter of speed. I believe surgery is a matter of precision and of quality you give to your patients.
Sir, excellent demonstration, and there
Of course,
lot of points.
any question, any comments, I'm happy to answer. I'm talking and talking, but please tell me if you want me to speed the video or whatever, or
No,
any
sir,
comment or
excellent.
any
Because
clarification.
we prefer this because this is a deferred live and real video, and lot of points that already you have highlighted. Just regarding, sir, this anterior gastrojejunostomy, you tried
Yeah.
your best to do just near to stapler line, but again, in my opinion, there is some ischemic area, some space between two stapler lines. Are you agree with me?
Well, partly. I mean, in my experience, I never had problems of blood supply intended as leaks due to a poor blood supply at the level of the stapler line. The stomach is very well supplied, so I mean, as an excellent blood supply. So uh, I do not believe this is a major issue when you do this surgery. But what I can tell you is that, of course, is not my routine to do this on the anterior face of the stomach. Sometimes I do on the anterior face, and sometimes I don't. I use the posterior face. So this makes possibly some difference in the speed of the stomach emptying, of the gastric pouch emptying. Of course, when you have the gastrojejunostomy on the posterior face on the stomach, you have a faster gastric emptying. Conversely, if you have these on the anterior face of the stomach, the emptying is slower. But to go back to your questions, honestly, I do not consider the overlapping of suture that I don't have in any case, because I do not overlap suture. I'm very careful to not overlap sutures. but having these sutures so close is not a problem for the blood supply of both stomach or the jejunum. Now I'm closing, as you see, the hole with the a barbed wire. This is fantastic. This is amazing. These barbed sutures really changed my life doing bariatric surgery, because I have an excellent grip over the serosa. And as you see, this is a seromuscular. I do not take the mucosal layer. I always and only try to pick up the seromuscular layer, and this gives me a very good results in terms of closing effect, of closing functionality on the gastrojejunostomy. And I reach the angle from right to left. Then I revert the tip of the needle, and then I go back from my left to my right. And this is a double layer closing, basically. And this is made in this case with a Stratafix suture from Johnson and Johnson. Sometimes I use Johnson to do these passages. Sometimes I use Medtronic threads. They are both excellent quality sutures. And this double layer closing, seromuscular, once again, has excellent capability of excellent results in closing the hole. I have, of course, opened to use my mechanical stapler. I always take care not to overlap or the thread, the suture, and sometimes I go above the suture line, this in order to have even better quality of closing. Here we go. And now it's time to go on the jejunal part of the closing. And my final landmark is the first angular stitch I place it on my right side, of course, and this is my landmark for ending my job on the barbed suture. This tells me I'm on the right plan, I'm on the right side. I reached my final landmark. Probably one more suture. Yes, I will. Enterical part, and you see I reached my angle, and it's time now to finish by overlapping. You see the gastric pouch is totally overlapping the hole, and this gives a further quality to the closure of the hole I have opened to use my stapler. This is all manual, basically, but I love this, and to be honest, I never had great issues with this quality of closing. Uh, I of course, like any other surgeon, had got problems with the OAGB in terms of leaks on the gastric remnant and the gastric pouch, but I do not remember I've faced serious issues at the level of the gastrojejunal anastomosis. You see now it is perfectly closed. I'm strengthening, I'm tightening the thread. You see, in the end, you have, of course, it may appear a little twisted, but this is the posterior face of the stomach, of course. But in the end, you have an anastomosis between the anterolateral face of the stomach and your jejunal loop. The suture is retired, and this is my suture, my closing, my gastrojejunal anastomosis. This is rightly the posterior face, but in the end, I can check. You see, this is the anterolateral. You see, of course, this is the anterolateral, and now I finished basically my job, and probably I'm going to measure the length of the gastric pouch that you see is in this case very below the gastric remnant. This should be about 18 to 20 centimeters in the end. Let's see if I take the this is the Medellin blue test, of course, the checking the closure, the quality of the closure, and by injecting some Medellin blue dye, asking the anesthesiologist, of course, to inject some Medellin blue dye inside the gastric pouch at the level of the anastomosis. You see the pouch is inflating, the jejunal loops are getting inflated, and well, the hemostasis looks good quality. I'm twisting and turning the anastomosis, but there's no expenditure of any methylene blue. You see the closure of the stapler. I routinely do not use at all any supplementary stitch to create what my good friend Miguel Carbajo defines the anti-reflux suture, the anti-reflux valve. He creates by using a suture between the angle of the jejunum and the gastric pouch. I don't do this. I believe it's not useful, and I definitely do not believe this stitches improves the quality or of your eventual reflux. This is the finishing of the surgery. I routinely, I would say, never close the Peterson space. There is no need, because this is one anastomosis, gastric bypass. You do not interrupt any meso, so there is no need to close the Peterson space. I routinely do not this. Once again, I make a check with the orogastric tube, and then the length of the gastric pouch is measured. This is 5 centimeters, 10 centimeters, and going below is about 18, I would say, to 20 centimeters. That is a very good average of length for a gastric pouch. Sometimes to improve the hemostasia at the level of the stapler line, I use some glue, some hemostatic glue, and well, that's all. I do place a drain tube behind the anastomosis for the first 24 hours, and it goes behind anastomosis and then goes up up to the east angle or the EG junction, and this is in order to to see if you have any bleeding in the first hours, or eventually a leak, but of course in the first period from surgery. Well, that's all. It's
Sir,
finished.
sir, excellent demonstration and a lot of points. So, especially the point that you dissect parsa pellucida and the concept. So, gas will go backside, and it was amazing. Then, definite making the window is much easier for a surgeon. Sir, Professor Lauren Layani is also live with us. Professor, any comment, any question? Professor Laurent.
Can you hear me?
Yeah, sir, we can hear you.
And Mario, you can hear me too?
Bonsoir Laurent, comment allez-vous?
Ça va et toi?
Bien, bien, très bien.
Look, it was a very nice demonstration. I just would like to ask you something. I mean, you have during your gastric pouch, you are stapling horizontally the first shot, and then you take 1, 2, 3 shots without any bougie inside the gastric tube, and you do this with your experience and your feeling, and then you pass the bougie. I think this is very good for you, but I feel for teaching purposes, it's not a very good idea. I do a lot of teaching in different countries, and I believe if you teach them to shoot without bougie, you can have a lot of problems. So for you, Mario, I know you, and it's no issue. But I am absolutely convinced. Then, for teaching purposes, you must, when you do your first horizontal shot, and then you start your first, second, third, you must introduce your bougie in the lesser curvature of the stomach and staple along the bougie like you do for the sleeve.
I agree definitely, Laurent. You're absolutely right. This is my technique that I've developed following dozens and dozens and dozens of cases. So it's right. It's the experience that leads me to do what I've shown you. But the only comment I can make with regards to your observation is that as you have seen, I go very, very low. I go much below the crow's foot at the antrum level. So it could be difficult because sometimes the bougie is I would say somewhat hard. So it could be, especially for the first firing, could be difficult. But if you want to educate people to do this technique, I agree with you that could be more useful and safe, of course, to pull down your bougie. I agree with you.
Okay, thank you. Merci.
Sir, excellent demonstration. So my one question regarding this little twist of gastrojejunostomy. When routinely we do anterior gastrojejunostomy, there is chance of twist. My question: have you experienced to fix your gastrojejunostomy to remnant side of antrum anytime you see yes there is a twist, and it's better to do a suture or anchoring suture with antrum?
No, the answer is no. I'm convinced that the pouch is that is the strength of the OAGB. That very long gastric pouch is very well supplied. The vascularization is a good quality vascularization, is much better than the vascular supply you have when you prepare gastric pouch for a Wu-Y gastric bypass, for a standard gastric bypass. The long pouch gives you a very good quality in terms of blood supply. So in my opinion, you should leave your pouch free to rotate Okay, so this is what I do, of course. In a very, very few cases, I fix it because I didn't like the position the pouch got. I fixed the pouch to the gastric antrum, to the gastric remnant. But routinely, over 100 cases, 99.9, I don't do that. I leave the pouch free to rotate. As you've seen in the video, the anastomosis was between the anterolateral face of the gastric pouch and the lateral face of the jejunum. So it is not too twisted. So I believe if you try to reach this position is a good compromise in the end. So once again, going back to your questions, I do not fix at any time the pouch to the antrum.
Sir, your patient never faced any functional obstruction, because sometimes patient is vomiting, your endoscope will go easily to efferent limb when there is a little twist, but patient is not tolerating liquid diet. Have you faced?
Uh, to be honest, you've seen the anastomosis is 4.5. Normally is wide enough. Of course, your comment is regarding the twisting of the gastric pouch that could make the discharge, the gastric emptying more difficult. To be honest, this has not been a great problem in my experience. Possibly because the anastomosis is wide enough. I don't know, but I have no experience this twisting to give me major issues regarding the emptying of the gastric pouch.
Sir, just last question. So regarding concerns, so now you have decades experience of bariatric surgery, and definitely you did a lot of Roux-en-Y, sleeve gastrectomy, so other surgeries, and nowadays, so you are leader of OAGB. What is your main concern of OAGB? So when you did the surgery, so sometimes you think about, oh my God, bleeding, patient was male patient, central obese, hypertensive. So what is your main concern, early concern? I am not talking long time and malnutrition, just within 2 3 days.
Yes, this is a good point. Um, mm, I believe that the OAGB is good for, I would say, 65 to 70% of our patients, all our patients. But when I do not use the OAGB, I would not use the OAGB if my patients have a serious reflux. If we are discussing about grade C or D or even Barrett's esophagitis, Barrett's esophagus, I would not use an OAGB in that case. Or when I would not use an OAGB, well, is very is a very good response with diabetic patients, with very super obese patients. It is a good technique, and but I don't know, possibly in very young patients, possibly could be a relative contraindication. If I have an 18, 20, 22 years old female uh, still waiting for getting a pregnancy, or possibly I would be more cautious, but it's not an absolute contraindication. But once again, if I have a 40 to 42 BMI women, young women, I would not probably do an OHGB. If the patient is okay, I would go for a sleeve. And conversely, if I have patients with a serious reflux, I've no doubt about that. I'm going to Roux-en-Y gastric bypass. That is another excellent approach to our bariatric patients.
Sir, so much thanks, and it was one of the best session, no doubt, and especially for my viewers, youngsters. It was great opportunity to hear direct from someone who is one of the pioneer of OAGB hybrid technique. So we will continue our this Deferred live interview series, and next week Tuesday evening we will be with another legendary bariatric surgeon. Sir, so much thanks for your support. You are always really sportive, and hope see you soon.
Thank you for your invitation. I'm happy to join you and your educational program. See you soon.
Thank-
Ciao.
Thank you, sir. Thank you, sir. Have a nice day. Thank you, sir.